Hey guys, good morning. So today we're going to talk a little about the inferior vena cava and the aorta. That's going to be our first day, Tuesday topic. So I'm going to actually pull out my PowerPoint. So first off, we know that both the inferior vena cava and the aorta are retroperitoneal, which means they sit behind the peritoneum, along with a couple other things such as the kidneys. We know that SAD pucker up is a good acronym to use for all the retroperitoneal organs, or the glossy for the intraperitoneal. Couple, fun facts. It's on the left side of the spine, so if we're going through and looking at it, you can see here it's going to be on the left side of the body, whereas the inferior vena cava is going to be on the right side of the body, or again, the spine. What happens is, again, we know that the aorta branches off, it becomes the ascending aorta, and that turns into the aortic arch, where it's got those three branches that we've already discussed in previous lectures. Then it goes through, becomes the thoracic aorta, or aka the descending aorta, before it goes through and pierces the diaphragm, at which point it becomes the abdominal aorta, which is what we typically go through and we inspect as general sonographers. So we're going to talk about the different branches of the aorta. So, and then the way it's going to look on ultrasound, as well as the inferior vena cava as well. So starting off, the first branch of the aorta, as you can see right up here, is going to be a celiac axis, or the celiac trunk. Both ways it may be described as. So written out, you're going to see it written as CA. Now the celiac axis is going to, again, be that first branch, and it's going to have three different little branches off of it. So if we're looking at the different branches, which we can go through and we'll look down here, but what we'll do is we'll just discuss the three branches and then we'll move to the ultrasound images. The first branch of one of the three branches off the celiac axis is going to be the hepatic artery. The hepatic artery is going to go and course towards the right lateral side. Again, hepatic, think of liver. The liver is located on that right side. So that branch off that celiac axis, that hepatic artery, is going to branch over towards the liver, aka hepatic, on the right-hand side. So another branch, major branch, and I keep saying major because we typically don't view one of the branches, which we'll discuss, but the other major branch of the celiac axis is going to be the splenic artery. We know that the spleen typically sits on the left side of the body, so therefore the splenic artery would be the artery off of the celiac axis that's going to course towards the left. Now finally, we typically have one little non-visualized sonographic artery as well, the left gastric artery. Again, we don't typically view it via ultrasound, so but those are the three main branches of the three branches of the celiac axis. You're going to have the hepatic artery, the splenic artery, and then the left gastric artery. Moving down, the second major branch is going to be the SMA, which you can see right here, SMA, which is going to course parallel with the abdominal aorta. So again, you're going to see it on ultrasound, where it's essentially going to be anterior and parallel to the aorta. So we know the aorta travels from superior to inferiorly. SMA does the same thing. It's going to be that second branch off the aorta, and it's going to travel parallel and anterior, or in front of that aorta. And then we have the IMA as down here as well. We don't typically visualize that. Moving down, oh, I'm sorry, go back up a little bit. Between the IMA and the SMA, just inferior to the SMA, we're going to have the renal arteries. So we have the left renal artery and then the right renal artery. Right renal artery is going to course towards the right renal or right kidney, whereas the left is going to course towards the left renal or left kidney. Now, if we look at my image right here that I've drawn, you can see that we got a nice clear image of that left renal artery. However, the right renal artery is going to travel posterior to the inferior vena cava. So what happens is essentially that once we go inferior to that SMA, I would say inferior, just slightly inferior to that SMA, you're going to see the two little branches come off, and again, that right one is going to go through, and it's going to travel, and it's going to go behind. It's going to course behind the the inferior vena cava before it travels over to that right kidney. Left one, again, clear path. Right one's going to course inferior or posteriorly to that inferior vena cava, or behind. Continue to move down, that's where we get that IMA. Again, we don't typically view that sonographically. And then just by the umbilicus, just past the umbilicus, we're going to have our iliac bifurcation, which we're going to talk about a little bit. But again, right and left common iliac arteries is what that aorta is going to branch into. So we're going to talk about the sonographic images. As far as the branches go, what you're going to see, you're going to have to memorize what they look like. But I personally think it's easier to go through, take an ultrasound image, memorize it in your head. What does it look like? Those of you who've been in the lab so far, at this point, we can look at this and say, hey, that kind of looks like the sagittal aorta. That's because it is. So this is what we're going to see in a sagittal plane. Now, again, remember sagittal, we're going to have our probe, and you're going to have it where you can see superiorly and inferiorly. However, to see right and left, you're going to have to physically move right or physically move left to see anything to the right or left of the aorta. But again, in a sagittal plane, you're going to be able to see the long axis of the aorta, so you're going to see a bigger portion of it, or a tubular anechoic structure. Again, the first branch off that abdominal aorta is going to be a celiac axis. Now what happens is it essentially comes off, you have your aorta, and the celiac axis is just going to project forward just slightly like this. So again, looking at it, if this was the aorta, all you're going to see is a little nub essentially until it becomes, again, the different branches that it does become, because it has 3. But when you're in sagittal, all you're going to see is, again, just a little nub or the little trunk of the axis. And then you would have to actually physically turn to see those right and left branches or be in transverse. Because again, if we're going through and we're in sagittal, you can see superior and inferior and anterior and posterior, but you can't see right and left. Now, if we have that celiac axis and immediately it pops forward and then courses right and courses left, you'd have to physically turn in a transverse plane in order to see those branches. So again, in sagittal, you're typically only going to see the celiac axis and the trunk in a short form. Whereas if you move down, the second branch off the abdominal aorta is going to be the SMA. If you move inferiorly, or in this case you wouldn't have to move because you would see it because you're in sagittal, and in sagittal we can see superior and inferior. But if you look inferiorly on your screen, because again, we're thinking of our screen, this is what it's going to look like. So if you look inferior to this celiac axis, you will see an SMA. And again, as I just stated, we have to remember the SMA is going to travel parallel with the aorta. So it's going to be traveling the exact same. It's still going to be a tubular structure. So essentially it's going to be one tubular structure in front of another tubular structure. Now, if I hold it just right, can't really see the aorta. However, if we're going through and we take a slice, all you're going to see are 2 tubes that basically sit next to each other. SMA is a little bit smaller in caliber in its diameter. But again, you should be seeing that a good portion of the way down. You'll get it nice and elongated like this in sagittal. Now, looking at this, we're not going to see the renal arteries unless we physically move. Why? Because again, if they're branching off the aorta, they're branching off and they're coursing to the right and to the left. And in sagittal, we would have to physically move to see those. Now, if we start talking about the transverse options, we have different areas sectioning. Same as here, but if we look at the sagittal, we can see the prox aorta, we can see the mid aorta, we can maybe, depending on the person's size, see a little bit of the distal aorta, but typically you're going to see a lot of the prox and mid. In an average sized person, average sized patient, you're going to see the prox and the mid aorta, and then have to just physically move your probe just a little inferiorly in order to see the distal aorta. Now, in a transverse plane, you're going to be able to see the right and the left, and again, still anterior to posterior. And again, this is assuming that we're using an anterior approach via ultrasound. You can come in coronally, there's different ways you can do it. But again, we're talking about this assuming that you're using just an anterior approach in the body. So if we're going through, we've taken our probe, always remember the notch is going to go towards the patient's right or towards you when you're scanning, because again, you're going to be on the patient's right hand side. So the notch is going to go towards the patient. If you flip it the other way, your image will be backwards, so it's going to look a little funny. Big indicator is you'll see the IVC on the left side or the right side of the screen and the aorta on the left side of the screen, and that's not the case. We know the aorta lies on the left side of the body or the left side of the spine. So if we go through, take our notch that's pointing superiorly and turn it towards the patient's right, you're going to see the inferior vena cava and aorta. Now in sagittal, we can't do that, because again, they lie next to each other, so we'd have to physically move back and forth in order to see one or the other. Whereas in a transverse plane, you're going to see both, but instead of seeing them as long tubular structures, you're going to see them as circles, because essentially what we're doing is just hacking it off right there, and all you're going to have is a little circular dot like this. Marker's a good example of that. So again, side by side, they're pretty much gonna look just like this. Now, again, in sagittal, they're gonna look like this, but we would have to physically move our probe to see one or the other. So, coming back, transverse, we're gonna have inferior vena cava on the right, aorta on the left. We're gonna start at the proximal portion. Typically, you're gonna wanna go through and try to get that pericardial space at the very, essentially the beginning of the aorta, the very initial part of the abdominal aorta. You want to visualize that. We look for fluid, things of that nature in the pericardial space. We'll work on the images. You want to see the diaphragm in that picture. But our goal is to get as proximal as possible. So we move up as proximal as possible. Usually the xiphoid process is a good landmark. It doesn't go anywhere in people. You go all the way up, and again, once you feel that resistance, you'll start to see it on the screen as a shadow. You know you're in a good spot. You can't really go any higher or any more proximal in the aorta. So we'll start up nice and high. Again, if we're in the proximal aorta, what you're typically going to see is that celiac axis again, because it's our first branch of the aorta. Now what we have, and now we're seeing, is the right and the left branch. Again, the right branch is going to be the hepatic artery that travels towards the hepatic, aka liver, or the splenic artery, which is going to course towards the left or towards the spleen. And again, just visualize that little squiggly line right there. That's going to be our left gastric artery. Now, we call this the Siegel sign. This is the Siegel sign. Again, you're going to have splenic artery and the hepatic artery, but this little chunk right here, this little portion right here, is going to be our celiac axis. Now, in some patients, you may get very, very little, like a very, very small one, maybe even smaller than the one I've drawn, or you may even possibly get one that's nice and long and curvy. It just depends on the person. Again, if they have a longer celiac trunk, it may look a little more curvy before branching off, and that's okay, that's fine, it's normal. But again, you want to be able to recognize the sonographic branches that we typically visualize. So if you see one of the branches and you see that Siegel sign, you're going to follow the one towards the right, that's going to be the hepatic, and towards the left is going to be the splenic artery. Now, with that, if we're going through, you can see here, it would be a little branch. That celiac axis puts those branches just anterior to the aorta and the IVC, because we know the aorta and the IVC lie next to each other. So typically what you're going to see is that hepatic artery branch coursing anterior to the IVC. So you're going to see that sonographically. It may not be a perfect visualization. Typically we just look for the Siegel sign. But again, if you see an anechoic black circle adjacent to the right side of the aorta, it's the IVC. Typically it doesn't have that nice round tubular appearance that the aorta is going to have. Why? Discussed it. Why does the IVC sometimes look a little smushed, for lack of better terms? Well, aorta or arteries have a thicker medial layer. Remember, thicker medial layer to withstand that higher pressure system. So they keep their shape no matter what. They're like a plastic straw, whereas the IVC is basically like a bag and you put a hose in it and the water's flowing through it, and it takes the shape of the volume in which the fluid is traveling through it. So again, typically you may see it, either a circle, or it may even look like a little pointed structure just like that. So it depends though, and if you press hard, you may almost obliterate the whole thing because that medial layer is very thin, so they are compressible. Veins are compressible. We'll discuss more a little bit later as to why, but if you press hard enough, you're gonna smash out that inferior vena cava completely. It's really easy to do, especially on smaller patients. Now, again, this is right here, doing a little cross cut right here. If we move down, we start to see the SMA and the renal arteries. Right and left renal artery, right and left renal artery, they feed the kidneys. So this is where things get a little confusing. This to me is one of the more complicated areas when it comes to the abdomen as far as recognizing structures. But once you get it, you get it, so that's good. So again, we're gonna go off the aorta. Again, if we're going through, we're gonna be like right about here. And again, we can't see the renal arteries because they're coursing right and left, and we're in a sagittal view and you can only see superior and inferiorly, not right and left unless you physically move. But if we were in a transverse plane, again, where we go through, turn on it, you're gonna go through, you're gonna see the aorta. Again, nice, pretty perfect circle because it's gonna hold that tubular structure, that circular structure because of that medial layer. And then what we're gonna see is we're gonna see the branches of the right and left renal artery. Now, the left renal artery is pretty much unrestricted. It just goes through, courses its way till it hits the left kidney. However, the right doesn't do that. If you can see here, and if you can look at my image up here, the right renal artery is actually going to course posterior or behind the inferior vena cava in order to get to that right kidney. So again, if you're looking, you're going to see the inferior vena cava, and you should see a nice, pretty right renal artery coursing posterior to it. This is going to be your elongated version of it. Now, if we were to go through in our transverse plane and turn on this, you're only going to see a circular dot posterior to the inferior vena cava, which we're going to discuss right over here in just a minute. But again, if you're in transverse, you have to think about how the aorta lies and how the branches of the kidneys are going to lie, the branches of the renal arteries are going to lie. In order to get the long axis, you would have to turn in transverse because they course transverse in the body or horizontally in the body. If you're going through and you're scanning and you stay in sagittal, once you get past the aorta, you're going to just start seeing the circular cuts of the renal artery, especially behind the inferior vena cava. You're going to start seeing circular cuts to the right and then back to the aorta, and then if we move left, you're going to start seeing circular cuts to the left until we can no longer see it due to either bowel gas or whether it just bifurcates and it gets just way too small in diameter. Either or, sometimes you can see them the whole way over. It just depends on the patient. But again, if we're looking at this, the left is going to branch off the aorta and course towards the left. The right is going to branch off the aorta and course towards the right. During that coursing, it's going to travel behind or posterior to the inferior vena cava on that right-hand side. Now, renal veins are going to be right around here. Typically, they lie almost one on top of each other, but I wanted to, for imaging purposes, kind of separate them so you could see the difference. So, but again, what you're typically going to see here is, again, they're lying like anterior and posterior to each other. So basically what's happening is the renal veins are essentially lying just like this with the renal arteries. However, if I draw that on the board, you guys can't really see it, so we had to just turn it up a little bit for you guys. But again, typically they're going to look just like this. You're going to see those renal veins coursing just anterior, and in this case it's going to be to the aorta. They're going to go over and eventually it'll course anterior to the left and to the right. But here, the left branch of the inferior vena cava is going to course towards the left kidney, so the left renal vein will course towards the left kidney. However, its course is a little different than how the right renal artery had to course completely behind the IVC. So the left renal vein actually courses anterior to the aorta, so it stays in front of the aorta, whereas the right renal artery goes behind the IVC. So that left renal vein is going to course anterior to the aorta. However, it courses posterior to the SMA. Well, what does that mean essentially? Essentially what you're going to have is a sandwich. So if we look up here, we can see this left renal vein coursing, and it's going to be just anterior to this aorta. However, that branch, that parallel branch off the aorta, that SMA, it's going to go essentially right in between those two, to where, again, you're going to have an image that looks like this if we're in a transverse plane. If we were in a sagittal plane, you would get more of this, and it would be very, very hard to see that left renal vein somewhere in here. Possible, pretty hard, but we could do it. But in transverse is usually where you get your best image. So again, that left renal vein is going to course just behind or posterior to the SMA, which is that parallel branch of the aorta, and just anterior to the aorta, until again it travels over and it hits that left kidney. And again, that's what is essentially going to go through and drain that left kidney back into the IVC. The blood goes through the renal arteries, from the aorta, goes through the renal arteries, gets to the kidney, does its little thing, and then it comes back out, and we'll go over all the branches, don't worry. But it's going to come back out and essentially drain through the left renal vein. So veins drain, arteries are going to be the ones that supply the blood. So again, going through, and you might see a little, but we know that they're typically smaller in caliber, and again, veins are very easy to compress, to obliterate them. So if you're going through and putting any sort of pressure on here, you may just go through and collapse the actual veins themselves. Be careful. This is a little harder because again, you have those two tubular structures essentially protecting it. So it's a little harder to compress here, but you will see it go through and it'll flatten out. And then typically what happens is once it gets through this little pathway, I like to call it, it's going to bow out just a little bit. So that's how you're going to be able to tell it's a vein versus an artery too. Arteries are very consistent when it comes to their size, their shape. Veins kind of do what they want. So if they have two arteries that are sandwiching it together like this, once it escapes that, it's going to go through, and again, if it's got a high volume, it's going to bow back out and allow for filling of that blood. Now, if we move distally, just erase that because we do eventually lose, sight of the typically we will lose sight of the SMA. Sometimes we don't. Sometimes we'll see it, travel for quite a bit, or we'll see the IMA pop up. But again, typically once we get towards the distal, this is what you're going to see with a little. And sometimes you may not see this because once we get to the umbilicus where things start to bifurcate, if you're just a little superior to that, you may be pressing a little bit, essentially smashing down the distal portion of the IVC. You may see some in your notes that they're called proximal. The reason that portion by the belly button is called the proximal IVC is because vascular sonographers actually go with the path of flow, whereas general sonographers use the body. So as long as you understand that the veins go through and they travel upward where they merge together and become that IVC, and that's where the IVC technically begins. I don't care how you remember it. It's everywhere you go, it's going to be labeled a little bit different, but technically speaking, the IVC begins right at the belly button, whereas the aorta ends or bifurcates at the umbilicus portion. So again, they're going to go through, travel up, veins are going to go through, merge together, become that inferior vena cava. I'm going to call it distal again just because we are doing general sonography, but you're going to see it in some of your stuff labeled as proximal, and that's why. It's because technically that's where it begins, but it is distal in the body technically. So again, I don't care however you memorize it, that's great. Just know that this is where the IVC begins and the aorta bifurcates and ends. So again, once we get down to that umbilicus, there's no more branches left until we get to the this iliac artery, the iliacs in general. I shouldn't say arteries because iliac arteries and veins are in the same spot. They bifurcate in the same spot right by that belly button. You're going to see just two tubular structures once you get to right about here. So again, here's where you're going to start seeing those renal arteries, those renal veins, the SMA in just a circular format. And if we move up, that's where you'll see that celiac axis, and then all the way down, you're just going to see those two circular structures sitting side by side to each other. And one may be a little flattened, one may be, the IVC may be flattened, may be hard to visualize. But again, that's all you should be seeing. So with that, there's not going to be really any landmarks other than those two vessels once you get to this point of the abdomen. There's gas, intestines, yada yada, but there's no organ type landmarks like when you're up here you have the liver. Once you get to the mid portion, you're going to find that we use the pancreas as a landmark. So once you get to distal, it always seems to be hard for people to understand. There's nothing there. There's nothing there other than those two vessels. Get them nice and clear. That's it. You want them centered on your screen, very pretty. That way they're able to be evaluated properly by whatever physician is reading your exam. Now, if we move just inferiorly to that umbilicus or that belly button, we're going to get the iliacs. We're going to get those common iliacs. It's going to start to split. That's it. That's all we get. So if we're going through here and we start moving down, 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 and we go chopping, and we cut it right here, you're going to see two circles. And again, you may see two, but they're very, very small in caliber. Typically, the main thing that's going to be popping up on your screen are going to be those arteries. And again, that's because they're stronger with that media layer, that thicker media layer. So again, here, once you get past the umbilicus, and this is all in transverse. These are all transverse images because sagittal, we can see, again, a good portion of the abdomen. These are all transverse. So again, if we're in transverse and we move all the way past the belly button, you're going to start to see a slow split or a slow divide of the aorta. So it's just going to go through and eventually start to branch out before they completely separate and go down the legs and become the internal and external iliac arteries. Now, with this, the one thing I want to discuss is what if we wanted to view the bifurcation in sagittal? Because we can easily view it in transverse, right? We can just go through, turn transverse, you can see them sitting side by side. However, we like to typically evaluate things in two separate planes. The reasoning behind that is due to artifact and verifying that things are real versus, things that we can make up, because as a sonographer, you can essentially create or destroy pathology. So how do we do that? Because again, if we're in sagittal and they're going like this, to the right and to the left, we'd have to physically move to see the right and the left. At that point, you can come coronally, and again, I won't do this, but you can come coronally just by where your belly button is and go and angle over. It takes a little bit of practice, and it's just an option. that you can go through and you can get a bifurcation of both the right and the left common iliacs together. So if you go coronally, and again, this isn't an easier image to get, but it takes a little practice, but it's nice to know that you have a different way to evaluate, a different window to evaluate those arteries. If you came coronally, you would see an image just like this on your screen. Now, and again, if we're doing this, the top of the screen would no longer be anterior because we're taking a coronal approach. It would be my right lateral going towards my medial or towards the left. So right to left, or again, right lateral to medial, however you want to word it, but right to left. And again, we're in sagittal. So again, superior to inferior because my notch will be pointing towards the patient's head. So, question is, which one's which? How do we know? How do I know looking at your images? I don't sometimes. If you're doing this and you come through the right, the top one is going to be the right because technically that's the first one you're going to hit, and then moving forward or continuing on, you would hit the left iliac. However, if you go through and you take a left-sided approach versus a right-sided approach, you're going to have the exact same image. You need to know what window you're using. You need to know what side you're coming in on. You need to understand, hey, this is the right on the top of my screen because I'm using a right-sided coronal approach, or hey, this one at the very top of my screen is going to be my left because I'm using a left-sided window, a left-sided approach. So again, this is assuming, the right and the left is assuming that I'm using a right-sided approach. However, if I use a left-sided approach, it will look exactly the same, but this will be the left and this will be the right. So you have to know. You could turn in the image, and if you label this left and this is right, I have to take your word for it because I'm not there scanning with you and taking the picture with you. However, once you get out into the field, it's very important to know that. Reasoning behind that is when you document pathology, you want to know what area is affected. So if you have, let's say, an aneurysm that goes through, and we'll explain, we haven't gotten to pathology yet, but this is just an example, so don't get too worried. If you have an example that extends into the iliacs, which they can do, I want to know which one. I want to know which one. So if you give me this image and you don't tell me anything else, I have no idea. As a physician, as a reading physician, I would have no idea if you just gave me this image and put sagittal bifurcation. Well, yeah, but what way are we coming from? Are we using a coronal approach from the right? Or are we using a coronal approach from the left? Doing something as simple as writing R and L could clarify everything. But again, it's important for you to understand what approach you are using as a sonographer, and just convey that. It doesn't matter which side you pick. Whatever side you get the better image is the side I want you to pick. But I want you to understand whatever side you're using is going to be this, or whatever approach, side approach you're using, that's going to be the first vessel you see at the top of your screen. It's not technically the top because we know top is superior. It's going to be the lateral. But again, if it's from the right, top is going to be right. And if it's from the left, the top of the screen will be left and the bottom will be right. So finally, fortunately, IVC is a little bit easier. There's not quite as many branches until we get to the hepatic branches, the left, right, and middle hepatic veins, excuse me, which we'll discuss a little bit, but those sonographically speaking, I like to show people because it's a little bit of an awkward angle that we go in and it's harder to understand until you're actually in there. But we'll do a little explanation, don't worry. But the big thing is if we're in sagittal, obviously these images correlate for both IVC and aorta. Aorta has more branches, so again, but we've discussed what the IVC does, so I'm not going to reiterate this. I'm just going to talk about the sagittal IVC. So again, if we're in sagittal for IVC, I like using colors that coordinate with the vessels that we're using. If we're doing a sagittal IVC, which again lies on the right side of the body, and we go through, we see that little red dot behind it. What is it? Well, let's think about the branches of the aorta. The first one's what? Celiac axis. Good. The first branch is going to be the hepatic artery. However, we won't see this behind the IVC. We would see it in front of or anterior to the IVC. So that can't be it, right? Well, let's go to the next branch. What's the next branch? SMA. Okay. SMA is a big branch. We should be able to see that. However, again, if we're in a sagittal plane, it's going to course parallel to that aorta. So we would, if we moved our probe, we would see it over the aorta. If we moved to our probe to the right and see the IVC, we wouldn't see the aorta or its parallel partner, that SMA, because again, we're physically moving off of the aorta towards the right to get the IVC in the picture. So it's not the SMA, that's not it. Let's keep going down our branches. All right, we got the renal arteries. How do they course? Horizontally, good, or towards the right and towards the left. So again, if we're looking at them and we're in a sagittal plane, you couldn't actually see the renal arteries again unless we physically move, and that's when we would see a circular cut of it. We would actually have to physically turn in order to get the long axis of the renal arteries. However, IVC, you can see it, because again, if we're thinking about those renal aorta, we're gonna be a branch of those renal arteries. So again, if we're going through and we're scanning that IVC, just posterior to it or just behind it, you're gonna see that right renal artery coursing towards the right. It's gonna be a very small dot, and it takes a little bit to actually get it out in some people, but again, it's important to know that that's what that little dot behind that is, because if you don't know, hey, what's that? That's weird. It looks like a little small cyst, because we know cysts are fluid filled. You need to understand that the basic anatomy, so you know that that's normal. Finally, with that, again, they're gonna go through, we've discussed how we have the right and the left iliacs and they merge together to form the IVC, and this is where it begins technically. Technically, this is where it begins, and a lot of vascular sonographers, which a lot of us, wear different hats. This is the proximal IVC technically. But again, if you're going through in the body, it's gonna be more distal in the body, but this is where it technically begins, whereas here, this is where the aorta technically ends and it becomes something else. So, okay, we're gonna go from our proximal, travel up. All right, we see the renal veins. Here they are again. Right next to the renal arteries, right between that SMA and the aorta, you're gonna have that left renal vein coursing between the SMA and the aorta, going towards that left kidney. Okay, let's keep moving up, all the way up. We have the 3 hepatic veins, the right, the left, and the middle. I'm not gonna go through and draw them out. There are some images in your book, and actually I believe your PowerPoint. I can tell you which one. Give me 1 second. So if you're going through, if you go on page 12, that's where you'll start seeing them. And I like to explain them a little bit, but we're gonna have the left, the middle, and the right hepatic veins. Now, some important things to know are that the veins get bigger in caliber as they course towards the IVC. So as they course out of the liver into the IVC, they're gonna start getting bigger. To me, they almost look like a sun. If everyone remembers the sun from the 90s, which I'm guessing half of you probably don't, it's gonna start to look like this when it starts getting closer towards the IVC. So again, a little bit of a bigger section as they course towards the IVC, and then they start to go course to the liver, and they start getting smaller and smaller as they branch off and have their little tributaries. So if we're going through, and this is where it's a little confusing, and I can't wait to show you guys on Thursday, because this is the only one that I think needs a little hands-on explanation. The other ones, once you see them and you get them, that's that. However, with this, when we go through and we scan the hepatics, they're in the liver. The liver's pretty high up, and they actually go through, and if you look at, if you look at the liver, pop it on right here, this is where the IVC ends, and this is where our 3 hepatic veins come out. So how are we gonna get them? They're on top of the liver, and we can barely see the dome sometimes. What you're gonna do is you're just gonna come right under the ribs, and you're gonna angle up. So your image is essentially going to be from inferior to superior. So with that, we know that the hepatic veins are on top of the liver or superior to the liver or to the IVC. So what you're typically gonna get, and I'll just draw it right over here. I'm gonna have my color coordinating. And I'm not gonna draw the liver. The liver looks like the liver. But what you're typically gonna get is a little section that looks like this. It's not great, but it's supposed to look like a bunny. It's the bunny sign. And again, technically, we're going from superior to inferior, and we're gonna be in an awkward transverse plane, but it's technically gonna be that this is gonna be the left, whereas this would be the right. So, right side, I don't know, that's actually gonna be the middle hepatic vein. In order to get that right hepatic vein, you would have to turn just a little bit, and what's gonna happen is it's going to elongate right here. Sometimes you may get all three branches, however, that's not always the case, but you should be able to get the left and the middle together. And then again, that right one, a lot of times we have to move and we have to turn on it just a little bit, but you're gonna see that coming here. And again, they all branch off of, and I don't wanna say branch off of, but they're all connected to the IVC. So if you see the IVC and you see three big branches, those are your hepatics. I say that because the portal system, which we're going to discuss tomorrow, does not, I repeat, does not intersect with the IVC, with its tributaries, with the aorta, with its branches. It does not intersect. It lies near it. It lies anterior to a lot of the things, but it does not intersect. So if you're seeing this IVC and some branches, they're probably hepatics, especially if you're seeing liver. Oftentimes we'll get it where, you know, I'll ask you guys a question, hey, you know, what is this and this and this? And I'll get somebody who will put portal vein, left portal vein, right hepatic vein. You're never gonna have where those things are connected to the same thing. So again, this would never be the left portal vein and the right hepatic vein. They're never going to intersect or dump into the same area. The portal veins, which we'll discuss later, pull blood from the GI tract, the intestines, and formulate their own little specific pathway to merge in order to go into the liver and feed blood into the liver. These drain the liver. So, and again, there's three of these branching directly off the IVC. Again, we're talking about the portal veins later and what makes them different. But typically with these, you're gonna see three branches like this, whereas the portal vein, it's gonna be one main branch and then two little pitchfork almost like branches, which are gonna be the right and the left. So here, three branches, they all essentially terminate into the same IVC. Portal veins are gonna look a little different because they're gonna have a pitchfork in the road essentially. All right, so again, just a quick refresher. The splenic artery is going to be one of the branches off the first branch of the aorta. That first branch of the aorta is the celiac axis. The branches off the celiac axis are the splenic artery, which goes to the left, the hepatic artery, which goes to the right, and then the left gastric artery, which we don't typically visualize via ultrasound. Again, with that, you're typically not gonna have any branches in your IVC in this picture. You're just gonna see these two in our seagull image. Celiac axis, aorta, splenic artery, hepatic artery. Moving down, we'll have the mid-aorta, midsection. You're gonna see pancreas in this picture, which we'll discuss once we get to the pancreas packet. But here, you're gonna see a crosscut of the SMA just anterior to the aorta, and then sandwiched between those two, you're gonna have that left renal vein. Now the IVC, again, you're gonna have just to the right of the aorta, and you're gonna see that left renal vein coursing in between the aorta and SMA. And what you'll also see is the right renal artery coursing posterior to the inferior vena cava. We're gonna stop for a second because we haven't discussed it yet and we're gonna get to it. This little black dot right here. I don't know if any of you actually see it. I don't know if you can see it. So this little dot right here is gonna be the right diaphragmatic cruise. Long story short, it's gonna go through, it's gonna be essentially gonna connect across, we'll go through, you're gonna see it anterior to the aorta as well. We'll discuss it later. But this little this right cruise gets confused with the right renal artery a lot. On the board, artery is red, diaphragmatic cruise is black. However, that's not the case on our screen. The aorta, the branches of the aorta are gonna be black, and that diaphragmatic cruise is gonna be black. They're gonna sit next to each other like this. If you don't get a clear picture of the aorta, you're gonna get one or the other. I don't wanna drop a finger. So again, if you're getting that, you're gonna see, if you don't get the nice clear picture of that right renal artery, you may see something that looks very, very similar to it. And once you put blood flow on it, you're not gonna get blood flow to it. The reason is it's not an artery. It's essentially just gonna be cartilage and tissue. I'm drawing a blank with the actual word right now. But it's not gonna have blood flow, it's not supposed to. The problem behind that is if you call that the right renal artery and you say that there's no blood flow to it, there's a problem. Whereas you might have just been a little too low, your angle might have been a little off. You wanna find a connection point between the aorta and that right renal artery. With that, typically, the diaphragmatic cruise is gonna lie pretty posterior to the aorta, very, very close to it, but it's gonna lie on the posterior aspect of the aorta, whereas that right renal artery is typically gonna be a branch anterior portion. It's not gonna shoot off like the celiac axis is, but you're gonna typically see it towards the anterior branch of the aorta. So it's more like an anterior horizontal coursing. But again, you're not going to typically see the branch coming from here. You're going to typically see it coming from more of the anterior aorta, and it's going to have blood flow. That's how you know you're in the right spot, and that's how you know you have the right thing. Again, you're new. None of you shouldn't have blood flow when it comes to that right renal artery. So if we're finding it and we think it's it and you put blood flow on and it doesn't light up, it's probably not the renal artery, because all of you should have blood flow at this point. However, when you get out into the field, it's very important to understand the difference and what you may be seeing, and then doing a little more investigative work, because if you do get this and you're not getting blood flow on it, you want to verify that that's correct. And at the same point, if you're not getting blood flow on it, you don't want to ignore it, just be like, it's a diaphragmatic cruise, no big deal. Because again, if that person's not getting that blood flow to, blood perfusion to that kidney, they're going to end up with renal problems. So again, it's important to understand the anatomy and what lies near things that maybe can be a little bit tricky or trip you up. So moving down, again, we're going to go down, down, down. We're past the renal arteries and renal veins. We're going to get right to that belly button area, just a little bit superior to the belly button. Right before the belly button is where that bifurcation occurs. And you're going to see the distal aorta, and again, technically the proximal IVC. If you put distal here, I'm okay with it, but again, I want you to be able to explain to me, if I ask you how the IVC courses from posterior, or from inferior to superior, and when it merges together, that's when it becomes the IVC, as the aorta, as it courses inferiorly and it branches off, that's where it ends. So again, right here, proximal IVC, distal aorta, however, distal in the body. So, and then again, just at that level of that umbilicus, just below it, you're gonna, usually it's right at it. You can always go above it and angle down, or go below it and angle up, because sometimes getting that belly button, you lose that contact, so you may get a big dropout. That's a little fun fact. You can go below it, angle up, go to the right, angle over, go to the left, angle over, it doesn't matter. But what I wanna see typically, again, is those two little nice clear red anechoic circular structures, essentially demonstrating both the iliacs, the right and the left common iliacs. Again, finally, if you're in sagittal, you're going to see the right renal artery posterior to the IVC. Again, this is pretending that this is our ultrasound screen, so this is going to be anterior, this is going to be posterior, superior, inferior, and if we're moving along, which again, if we look over here, we take our probe, we move from the aorta to the IVC, you're gonna get a nice long cut, and you're just gonna get a nice circular cut right there of that right renal artery. With that, I'm gonna end it, and if you guys have any questions, just feel free to let me know, okay? Have a good day.